Hi, good evening, everyone. Just a quick sound check, if somebody doesn't mind just popping in the chat whether you can hear me before we get going. Great, thank you very much. That's perfect. So it's 7 o'clock Monday evening, so welcome back. So we surprised ourselves earlier when we were looking at when we last did a webinar. It's been about 6 weeks. So our apologies for being offline for so long. It's just been a chaotic few weeks for us, and I'm really glad that that so many of you have come back to join us for this next episode. So thank you so much, and again, sorry for having to change the date of this webinar so often. So I'm really glad to see a really good number of you here. So thanks very much for giving up your Monday evening. Hopefully you'll find this useful. Those of you that are new to us, I can see lots of familiar faces, but I can see lots of new ones too. So those of you that are new to us, we are STC Training Solutions. We're a first aid and pre-hospital care training provider based in Aylesbury and also in Uxbridge, and we deliver predominantly FREC courses, to be fair, and we've put together this online CPD series aimed at those of you going through the FREC pathway with a particular aim at those of you doing FREC 4. There's an expectation that you get to know a certain amount of anatomy and physiology and other bits and pieces for your FREC 4, not only for your exam, but also for your workbooks and for your CPD pre-reading and kind of post-course CPD that you're required to do. So there's a lot of information coming your way in this series. It's going to be quite a long series. We're by no means anywhere near halfway through yet. So you join us kind of towards the end of like a little mini series of anatomy and physiology and pathophysiology, should I say. So we've covered some anatomy and physiology already in the first couple of series, first couple of episodes, and now we're working through each system. Common kind of diseases. So pathophysiology is the study of disease, and you join us this evening for the gastrointestinal system or abdominal system, abdominal pathophysiology this evening. So those of you that haven't met me or seen me before, my name is Innes. I'm a paramedic by trade. I've worked for a couple of the ambulance services full-time for a good number of years, and now I work full-time in primary care in a GP surgery in the southeast. Obviously run STC Training Solutions on the side in my so-called free time, and of course Monday evening is traditionally the evening that we do some free CPD for those of you that are interested. So as I say, great to see so many of you. Those of you that are still joining us, welcome along. You haven't missed anything yet, just the introductions. I hope you find tonight useful. So just as I say, we are predominantly a FREC training provider. We do have some courses coming up fairly soon, actually. Demand has definitely spiked recently, so get in there quick before we lose these spaces. So the next courses with space on now, so we've got a FREC 3 course if you haven't started anything yet. FREC 3 is your starting point. That starts on the 25th of September. That's over 3 weekends, ending on the 9th of October, which is Saturday. That includes we include medical gas as a standard on our FREC 3 courses. You get the extra hours and the extra certificate. And we throw in ambulance care essentials in the course price there. Don't forget you get 10% off all of our courses just for joining us on the webinar. If you come through the webinar route, use discount code webinar10, and that'll bring that down to $355.50, which is I think a good price. FREC 4, we've got next one coming up fairly soon now, 4th of September. We've got we only do our FREC 4 courses over weekends. They were designed to be done kind of in 3 blocks so that you have time to do your workbooks in between. So that's how we run ours. They're over 7 weeks, but you only attend our training centre for 5 days of those. So if you are in the market for a FREC 4, do take a look at that. So 4th and 5th of September, then you go away and do workbook 1, come back on the 18th and 19th of September, then you go away and do workbooks 2 and 3, then you come back for all the kind of final dust up on the 16th of October. Hopefully if everything's in order, you walk away with a certificate the next day, which is the way it's supposed to be. So we give you a stethoscope because that's becomes increasingly useful, as you'll see tonight with a couple of things, and an ambulance care practice, which is the next one up from essentials, gets included in that course price again. You get your £49.50 off by using webinar 10. So what's that, £445.50. So we'd love to see you on one of those courses. Those of you that have FREC 4 already, we've got an ILS course coming up the end of this month, 22nd of August. We always run our ILSs on Sundays. So again, 85.50, isn't it, with your discount there, which I think is a very good price. And Safe Administration Life-Saving Meds, the 2-day add-on for FREC4 is £200 or 180 with your discount, which includes a copy of JR Calc. So again, good value there. That's the 11th and 12th of September. So that's the plug over and done with. Thank you very much. That's the only thing you've got to sit through and listen to. We want these webinars to be free, but of course, in order for them to keep going, we do need to see, well, we do like to see people come back and use our paid services to make these worthwhile. But hopefully this evening will be useful. As I say, the series so far, we've covered CPD requirements, we've covered anatomy and physiology in the first few sessions. We're in the middle of this little micro teach on common pathophysiology, with tonight focusing on the gastrointestinal system. We're looking at going on to maternity care in a couple of sessions time. Got a little bit more pathophysiology to get through yet. Then we're going to talk about patient assessment, particularly around paediatric assessment. We're going to talk about sepsis. We're going to talk about oxygen and Entonox guidelines. We're going to talk about some ECG basics, and we're going to talk about intermediate life support, or immediate life support as it's sometimes called. Hopefully you'll find something of use to you there if you're going through this pathway, or even if you've been through the pathway years ago and you just need something to come back to. Here we go. So tonight then we're going to talk about some common GI problems. So appendicitis, cystic fibrosis, we're going to talk about that. As you'll see, branches across a couple of different systems. We're going to talk about the inflammatory bowel diseases, what they are and what the differences are between the two. Gastroenteritis, good old DNV, we'll talk about that. Gallstones and the complications of that we'll talk through, and we'll also just go into some of the liver problems. There are loads, and this is obviously an introductory session. We're not going to be talking in huge amounts of detail about all of them, because that would go on for hours, but we'll cover some of the ones you've probably heard of in a little bit of detail tonight. So we want the session to be interactive. You'll see in a second we're going to use Mentimeter in the middle there. So if you get your smartphones ready, go to menti.com. There'll be a code to enter, and you'll be able to answer the questions as we go along. A little quiz, a couple of points through, and then a few questions at the end, just to make sure everything's sunk in. STC admin are off tonight. Charlotte is on an ambulance this evening, so somewhere in the vicinity of Slough, no doubt. So she won't be joining us this evening. But if you see her driving around, do give her a wave. Through the session, or indeed afterwards, if you have any questions, drop them on a text, a tweet, or an email to us at webinars@stctrainingsolutions.co.uk. More than happy to help out with anything we can. We have had some issues with our email recently, but it does seem to be settled now. So we seem to be receiving people's emails, and they don't seem to be randomly disappearing off to junk quite so much. So get in touch with us if we can do anything to help, especially through the evening. So recommended reading for tonight's sessions if you want to go away and further your learning. Obviously, ambulance care essentials and ambulance care practice on the two sides there are the ones that should be included in your FREC course anyway. The two in the middle, Pathophysiology, a practical approach by Rachel Story, and the Ross and Wilson, good old favourite anatomy and physiology textbook, are the two main ones that you're going to pull extra knowledge from if you find an area that you're particularly interested in, or you want to do it with CPD in a particular area. These are probably the two best books for those, and they're available to purchase through our website, or of course on Amazon if you prefer. So let's give Mentimeter a go then. So if you head to menti.com with your smartphone or your tablet or whatever you've got, and just enter the code 75747523. It's shown at the top of your screen at the moment. Depending which device you have, you might need to move the videos out of the way, but 75747523. And I want you to answer, what are the functions of the gastrointestinal system? Just a little recap from anatomy and physiology. What is the point of us having a GI system? Some questions coming through. Oh, Georgie, that's very kind. Thanks very much. I'm glad you enjoyed your course, and good to see you along tonight. Chris, oh dear, sorry about the signal. I'm not sure what I can do to help from my end, but I hope you find somewhere. Just a point for tonight. The session is being recorded. We'll upload that to YouTube within a day or two, and the PowerPoint slides will go up on our website for you to download if there is anything you want to refer back to later. Good, perfect. So we've got some questions coming through, some answers coming through. Perfect. So Hinali, just have a go through menti.com if you want to pop some answers up. They'll appear on the screen. Good. Digestion, excretion, purifying blood, removing waste, nutrient absorption. So I agree with all of those. Purifying blood, not so much. That's more a function of the genitourinary system or the urinary system specifically that we're going to talk about next week. But otherwise, absorption of nutrients, extracting energy from food, absolutely. Digestion, excretion, perfect. Perfect. Well done, everyone. So absolutely on the right lines. It sounds like lots of people are remembering their anatomy and physiology side of things. So digestion is the big word that's appearing there, and excretion very close underneath it. So they're the ones most of you are saying. Digestion is obviously the breakdown and absorption of food and that extraction of good stuff that we need to do the functions of the cells within the body, and of course excretion of the things that we can't use, the waste products, etc. So very good, well done, folks. Let's flick back to the slides and let's just have a quick recap of the digestive system parts. So we have the gastrointestinal tract, and then we have the accessory organs. So the gastrointestinal tract is this continuous tube from mouth to anus. Food goes in, food comes out, and obviously what happens to it in the middle is a little bit more complex. But basically your GI tract is this one continuous tube. Okay, so from the mouth, we swallow food, it goes down our esophagus and it ends up in the stomach, which is the top of our picture here. The stomach is where digestive enzymes and acids, etc., are added and start the process of breaking down food into something that we can actually absorb. Most of the absorption goes on in the small intestine. The small intestine is split into three areas, as you can see: the duodenum at the beginning, the jejunum in the middle, and the ileum is the kind of third section of it. They all do slightly different things, but basically the vast majority of absorption of food is done within these areas. And then you go into what's called the large intestine, also known as the colon. The colon is this larger winding passageway which starts down here in the cecum. The cecum is, of course, where the appendix is attached. The appendix is just protruding from the very beginning of the cecum there, which is the start of the large intestinal colon. It goes through the ascending colon, it goes through the transverse colon, through the descending colon, nice and easy. The sigmoid colon and rectum is where feces is stored ready for defecation when we open our bowels through our anuses. So the purpose of the large intestine predominantly is there is more absorption going on. A lot of the fluid that's usable fluid within our food is absorbed in the large intestine. But again, it's a different process. Every part of the GI tract has its own small function, but it's just a continuation of the absorption of anything good in the food. But predominantly, it picks up any of the water. Hence why our stools, our feces is predominantly quite dry, unless you've got some underlying issue going on with your digestive system. So good. The accessory organs then that we talk about. So the liver produces a lot of the enzymes. The liver also does a bit of kind of filtering of the blood to a certain extent. It starts to break down toxins within the blood. But within the gastrointestinal system, the liver is very useful for producing those digestive enzymes. And bile is then stored within the gallbladder. This little protrusion at the base of the liver itself. And then through the ducts, it goes into the small intestine, which is where into the base of the stomach and the small intestine, which is, and the bile is the substance that allows us to break down the vast majority of our solid food, things like that. And the pancreas sitting at the back is obviously instrumental in blood sugar control. Predominantly, again, it's another enzyme factory. Insulin and glycogen are the main ones that are secreted, and of course, as I say, for blood sugar control. And the pancreas is very important in conditions such as diabetes. And then you have the spleen. The spleen is a bit of a loner. It's considered to be an accessory organ of the gastrointestinal system, but actually the vast majority of the spleen's functions in life are with the cardiovascular system, actually. A lot of red blood cell kind of regulation and removal is done by the spleen, plus a little bit of storage of some of the white blood cells for the immune system. Again, but it's often considered as an accessory GI organ, but actually doesn't have very much to do with the gastrointestinal tract itself. So now that we've refreshed on that, so let's have a little flick back to menti.com. So we're going to ask the next question, which is, when I can get to it, give 3 signs and symptoms of gastroenteritis. Then what's oh, hang on, I think we've tell you what, we'll come back to that one. I think I've put slide in the wrong place somewhere along the line, because we're not talking about gastroenteritis just yet. We're going to talk about appendicitis, so we'll come back to the menti.com. We'll answer that shortly. So we have a question just come in. Yeah, my name is Ines, Aaron, so welcome along. Appendicitis then. So we've just shown you on the gastrointestinal tract there at the very beginning of that ascending colon, the first bit of the large intestine. It's known as the cecum. It's the area where the final stages of the small intestine basically empty into. And you have a small protrusion just at the bottom of that, which is down in the right lower quadrant. We often consider our abdomens to be separated into 4 quadrants. So the right lower quadrant of the abdomen is where you're going to find your appendix, right down in close to the groin, actually, on that right-hand side. So the appendix is just a small hollow organ. Its full functions aren't fully understood. There's some link to digestion of grass, interestingly. Whether or not we ever used to eat grass, I'm not quite sure, but those of us that don't have appendices, and I don't have mine, apparently can't eat grass anymore, so gutted by that. There is some link to the immune system, but again, it's not fully understood what the appendix's full functions were or are, or whether it, well, obviously we can quite happily live without them. I'm one of many that had their appendix removed as a child because of appendicitis. Very, very common illness, particularly in the kind of teenage years. And absolutely, appendix gets removed, and I can't honestly say I've noticed any difference, and I've never had the desire to eat grass, so I can't say I miss it. But generally, what happens with appendicitis is a small amount of stool, a small amount of feces is pushed into the appendix and can't get back out again. From there, it becomes inflamed, and that infection spreads to the lining of the appendix. So what have we got here? So fine. Yes, okay, yeah. So again, an slight immune response there. Thanks, Stuart, for popping that in. Again, there are lots of links back to the immune system, but again, not fully understood as to what exactly it does. But after infection, kind of resettling the flora within the stomach sounds like a sensible thing for it to be doing. So there we go. This picture, as I say, sums up quite nicely. Just inflammation of that appendix. Anything which says itis in medicine is inflammation of something or other. In this case, it's the appendix. So treatment nowadays isn't quite so straight in for surgery like it used to be. So it used to be just whip everybody's out, but now we do try and treat them a little bit more conservatively. That being said, they can be surgical emergencies. Sometimes, particularly when they rupture, they can cause sepsis very easily. They can make patients very, very unwell. So an appendix that's particularly painful, particularly if the patient has a high temperature and is looking quite unwell, can be a surgical emergency still. But generally speaking, with what we call grumbling appendix, which is the days kind of up to rupture, hopefully, where we try and treat it and try and keep it under control, is normally just oral antibiotics and plenty of fluid and rest, etc. But so things have changed a little bit from those of you that are around my age that had their appendixes out in their teenage years, which is almost any kind of abdo pain in that region, they just whip out your appendix just to see. It felt like. So how are we going to recognise it? So here we go from our kind of Dr. ABCD approach. So patients are likely to be responding normally. Again, of course, we're not talking about severe sepsis from a peritonitis where the appendix is ruptured and patients are crashing. We're talking about the early stages of appendicitis. We're likely to see normal response, normal airway, normal breathing. Again, breathing rates and heart rates can increase with pain and with infection. You're likely to see an increase in temperature. So of course, with that increase in temperature, a slight rise in respiratory rate and heart rate is normal. Obviously, again, as it says in red at the side there, if you've got any signs of infection, got to think sepsis, haven't you? So calculating a News 2 score nice and early. Those of you that aren't familiar with News 2, we're going to be covering it in patient assessment in some more detail coming up. So think about News and sepsis, of course. Blood pressure is unlikely to change in the early stages. Again, a bit of pain sometimes put your blood pressure up, if anything. Of course, in late stages, if you've got a ruptured appendix and in the throes of sepsis, blood pressure may well drop. ECGs aren't likely to change in anything we really talk about tonight. GCS, again, Glasgow Coma Scale, level of consciousness, again, unlikely to have changed much in the early stages, but again, as patients develop complications of the disease, GCS can, of course, drop. Blood sugar, it's unlikely to change that much. Actually, in healthy non-diabetic patients, you see a slight rise in infection, but actually it's unlikely to be that noticeable. You might go up from kind of 4 to 6, for example. Obviously, patients that are diabetic might see bigger changes, but again, blood sugar isn't going to be a reliable indicator in somebody with appendicitis necessarily. Again, pupils, you're not going to get any kind of changes in intracranial pressure, so we're not likely to see pupil changes. On your exposure examination, what I've tried to do this evening with all of these is just try and separate how the different types of abdominal pain sound when you're asking your Socrates. So likely to see raised temperature. It is an infection and often can be bacterial, so it's likely to raise your core temperature up slightly. Abdominal pain, so we generally talk about abdominal pain starting quite generalized, not really anywhere, just kind of a central cramping or even just a dull background abdominal pain, but then slowly but surely it tends to localize, it tends to settle down in that right lower quadrant, RLQ, if you see it as right lower quadrant, LLQ, left lower, RUQ and LUQ being right and left upper quadrants. So RLQ, right lower quadrant, it's likely to be a sharp pain, a sharp stabbing kind of pain, and that's just the way the nerve endings all finish around the protective layers of the stomach. The abdominal organ, sorry. It's likely to be very, very painful on standing. It's likely to be very, very painful on palpation. You often get that rebound tenderness that you may have heard of. If you push down in that right lower quadrant, that will be painful itself more than likely, so be careful with how much force you do that. But as you release, if you release quickly, you quite often have a shooting pain in that area, and that's known as rebound tenderness. There are some other tests you can do which involve bending the leg, which is worth having a look for obturator and psoas, PSOAS. So obturator and psoas signs are ones to have a little Google of, and that's just various leg movements that you get the patient to do, and if that increases the pain in that right lower quadrant, then we can very happily say that this could be appendicitis. Always ask though, always ask in part of your past medical history and past surgical history is, have you had your appendix removed? I can speak firsthand, there's nothing more embarrassing than referring someone off to the surgical SHO for query appendicitis only to have a phone call back a couple of hours later saying, rather jokingly I hope, we went and had a look for his appendix, we couldn't find it. So don't worry, it had been taken out several years previously. So don't fall into that trap, I've done that. So here we go. So treatment then, I'll go through the treatment this evening. There's going to be a lot of repetition this evening with how we're going to treat a lot of these patients. So calming and reassuring, moving to a quiet environment if possible. Taking a full history and a full set of observations. We're going to do that for every patient, aren't we? But do remember Socrates. Socrates is your friend. So we'll talk about it more in patient assessment when we come up to that webinar, but the site of the pain, the onset of the pain, the character of the pain, does the pain radiate? Do you feel it anywhere else at all? Any associated symptoms, any nausea, vomiting, dizziness, diarrhea, etc. Time pattern is kind of how is it coming and going. Exacerbating or relieving factors gives you the E, and then S is your pain score. It's really important to get a pain score. A lot of these conditions we'll talk about this evening will involve pain. And one of the number one things we should be doing for our patients is relieving them of pain. Actually, we're not very good as an ambulance service. I know we were constantly reminded that we're not very good at addressing pain. We don't give out pain relief as readily as we perhaps should. There's a variety of reasons. We're not horrible people, but there's a variety of reasons why we don't address pain as well as we could. So do remember, if the patient's got a high pain score, give them some pain relief, and you'll have a few options available to you, no doubt. Always calculate in use 2. Any sign of infection, always think, what's their news 2? And actually, as I say in my classroom sessions, news 2, whilst it was designed to spot sepsis, is really useful for spotting unwell patients anyway. But we'll talk about that more on the patient assessment scenarios that are coming up. Good. Appendicitis, as I say, can be a surgical emergency, so it may be a time critical thing. We don't want to be dilly-dallying if the patient's particularly unwell. Again, if they've got sepsis, we're going to be treating them for that anyway. There is a whole session coming up on sepsis. Pain relief is really important. Entonox is very effective in appendicitis. So the reason I always say exclude bowel obstruction first, so you'll recall, those of you that have done FREC 4 and done your medical gases or done medical gases on FREC 3 and are trained to give Entonox, you'll know that one of the contraindications is suspected bowel obstruction, isn't it? So with any abdominal pain, I expect you to ask a few questions to just try and rule out bowel obstruction. Of course, that would be a several day history as a minimum of not having opened their bowels and being constipated and bloated and generally uncomfortable. But if we have an acute appendicitis often presents with diarrhea as well. Then it's unlikely that we're going to have that history suggestive of bowel obstruction. Paracetamol is always safe to give for any abdominal pain. That's not a problem. And for all of the abdominal pains tonight, I'm just going to say avoid aspirin and ibuprofen or any anti-inflammatories along those lines. There's diclofenac, there's naproxen, there's loads of other types that are out there and available that patients may have in their house and may ask you if they can take it. Just with the anti-inflammatories in acute kind of flare-ups of bowel problems can sometimes make the situation worse until you fully understand what's going on with their underlying kind of gastric problem. Some anti-inflammatories, as I say, can make the situation worse, particularly if there's any hint of bleeding going on within the system. Good. And then, of course, we're going to monitor closely, like all patients. These could be time critical. These patients could deteriorate. If their appendix is ruptured and they're getting sepsis, then, of course, they are going to be quite unwell. So consider paramedic support for pain relief. Obviously, paramedics in the UK carry, at the very least, they'll carry morphine. Some paramedics carry even stronger stuff than that. But morphine, again, is very useful in situations like this. Or even IV paracetamol, which can be more effective than giving it orally, particularly if the patient's vomiting, obviously. So, good. So we're coming on to cystic fibrosis, which is the second condition we're just going to go through tonight. So cystic fibrosis affects two systems, so hence why we've got some of our friends, the alveoli, up on the screen here. So you see in the picture here, we've got kind of excess mucus production, which is the theme of cystic fibrosis. In a normal healthy airway, as you can see here, versus cystic fibrosis, you get inflammation of the lining of the small bronchioles and the alveoli sacs themselves, and you get that excess thick mucus. So cystic fibrosis is not a particularly well understood condition, but it's a genetic condition in which, or it's a hereditary condition in which the mucus you produce is far thicker, far gloopier, and far harder to clear. Blocks more easily, etc., than it would be in a healthy adult. Now that's to do with sodium balance, and it's to do with how the body deals with fluids. But it causes two big problems. One in the lungs, so the respiratory system is affected by cystic fibrosis. It causes thick mucus to build up within the small airways and within the alveolar sacs. And of course, anything that impairs gas exchange is obviously going to cause breathlessness, low oxygen, high carbon dioxide. And of course, lots of other kind of complications as a result of that. Coughing isn't always effective because the mucus is so thick and gloopy that actually normal cough reflex can't clear it. Hence why these patients often take a concoction of medicine to try and thin the mucus slightly, and also have respiratory physiology in which, where they get their chest beaten and things like that to try and loosen the mucus. So the other big area where this can affect is within the gallbladder, actually within the pancreas and within the supply of bile to the gastrointestinal system, so through some of these accessory organs. So actually from the gallbladder and the pancreas are the two most affected. Again, the bile becomes thick, it becomes gloopy, it blocks things, it causes localized inflammation, it can cause lots of tummy pain. It also affects digestion, so a lot of the digestive enzymes can't get through into the stomach and small intestine, and food isn't absorbed properly. So actually, a lot of food is wasted. It travels straight through the system very, very quickly. A lot of patients with cystic fibrosis have to have very high calorie diets, often things like Ensure and those equivalents of kind of peg-fed supplements. So yeah, not a pleasant condition. It is life-limiting. Often, patients with cystic fibrosis do tend to die a lot younger, and not very pleasant quality of life, particularly in bad cases. And of course, with both of these things, particularly with the respiratory system, you're likely to get secondary infections, so like secondary bronchitis and pneumonias, etc. Within the gastric system, again, likely to get secondary gastroenteritis, gastritis, cholecystitis, which is inflammation of the gallbladder, all of these types of things, which can be quite troublesome for these patients. So again, how are we going to recognize, this is quite a broad subject now, but how are we going to recognize cystic fibrosis? They're going to have a history, they're going to know. Again, these patients will be born with this, will know it as a baby, they'll have it, they'll be born to parents with cystic fibrosis. it's one of those diseases that it's not just going to spring up on you in your teens. You're not going to go to a patient in the first presentation of cystic fibrosis. This is something they'll be living with, and generally you'll turn up to them, particularly if you go and work for an ambulance service anyway. You'll turn up to them when they're having complications, i.e. acute respiratory distress or chest infection or acute abdominal pain, or cholecystitis or something along those lines. So you'll be in there to support their breathing or to support pain relief and get them up to hospital. So again, traditionally it affects the lungs more acutely if we want to kind of look at it that way. So it tends to be more of a productive cough, a cough where mucus is coming up. Obviously, not all of it is. Raised respiratory rate, decreased saturations, increased carbon dioxide, difficulty in breathing, coarse crackles on auscultation. So when you're using your stethoscope, you're going to be hearing these coarse crackles. So air traveling through thick mucus is going to give you that real low-pitched crackly noise. Raised heart rate, again, with the respiratory distress, we're likely to have normal blood pressure, normal ECGs, generally speaking. GCS, again, in severe cases of secondary infection, we're likely to see reduced GCS. Again, BM and pupils tonight aren't really going to change too much. Raised temperature if secondary to infection, or if there is secondary infection there, sorry. Weight loss, weak lethargy, that type of thing. So again, weight loss is really quite characteristic, or not weight loss as such, but really struggling to keep a steady weight is very characteristic of cystic fibrosis. And again, occasionally getting those abdominal pains where they get secondary abdominal infection too. So again, quite a broad one there. So treatment of cystic fibrosis, not very much we can do outside of hospital, to be fair. Calm and reassure, move to a quiet environment, and full history and calculate your news too, again, if you're worried about infection. Chest examination, so if you're breathless with it, then considering some salbutamol if they've got a wheeze, again, for those of you that have your SARM qualification or another qualification that allows you to give nebulizers, considering a salbutamol nebulizer. Again, oxygen, if the saturations are low, it's possible. Monitor closely, transport to the appropriate facility. I think considering additional support for medication administration, and don't forget the abdominal side of things. If you do have an acute abdominal presentation, again, it might just be the case of pain relief and requesting senior clinical support if the pain relief you have available isn't sufficient or etc. So a very broad subject, but hopefully that's been useful for you. So inflammatory bowel diseases then. Inflammatory bowel diseases, two types we're going to talk about. So Crohn's disease and ulcerative colitis. Okay, so they're both inflammation of various parts of the gastrointestinal tract. They're not particularly understood. It's not sure why some patients get them and some don't. Okay, the difference predominantly between the two, Crohn's can affect all parts of the gastrointestinal tract. So we can see that there's some areas of the small intestine affected there, and various parts of the large intestine. Whereas ulcerative colitis tends to only affect from the kind of splenic flexure down. So from that descending colon on the right-hand side of the page there, ran through the sigmoid colon and into the rectum. That tends to be the area that's only really affected by ulcerative colitis. And ulcerative means degeneration of the tissue. So you do actually get ulceration within the lining of the colon. And of course that affects absorption, but it's intensely uncomfortable. It's intensely painful in a lot of cases, but very, very uncomfortable. Affects digestion of some of the foods. It can be triggered by some food. It can be triggered by stress. It can be triggered by other illnesses, etc. Now they tend to be hereditary. It tends to be a link to some family connection, but again, that's not always the case. Again, why it's not terribly well understood. And these are considered to be autoimmune diseases, i.e. the immune system is attacking itself. And again, we don't particularly understand a lot of these autoimmune conditions, but both equally prevalent. I see lots of patients day to day with Crohn's and ulcerative colitis. They're difficult conditions to manage. You have to kind of manage the flare-ups in the hope that they spend lots of time in what we call remission, where their symptoms aren't playing up. This isn't something they typically have every day, and they will know what causes them to flare up and try and stay away from those. But sometimes it just flares up for no obvious reason. So, as I say, main difference: Crohn's is inflammation of the gastrointestinal tract at various locations. and ulcerative colitis is just within those later stages of the large intestine, the descending sigmoid and anus. So good. So recognition features again. So for both of these, so not normally associated with signs of infection. Again, you can sometimes get raised temperature with both of these conditions as the immune system goes a bit haywire. But generally speaking, we might have some raised respiratory rate, raised heart rate with the pain. Blood pressure is likely to be normal. ECG is likely to be normal. GCS, blood sugar, pupils are all likely to be normal. Again, possibility of a raised temperature. Often diarrhea, very often that's the stages of the first signs of an acute flare-up is that acute diarrhea. With ulcerative colitis particularly, you get blood. Obviously, ulceration of the colon is going to bleed. So you get that fresh blood, bright red blood in the loose stool. Loss of appetite is common with obviously the nausea and other just symptoms that you get with general abdominal discomfort. So the abdominal pain in this one likely to be cramping. It's likely to be generalized, it's likely to be all over the place. Ulcerative colitis, obviously, with it being more on the left side of the patient's abdomen, tends to give more of a left-sided abdominal pain, whereas Crohn's tends to give a more generalized. Tends to get worse with eating, it tends to ease slightly with bowel opening. BO is going to the toilet, opening of bowels. Again, this can vary patient to patient, but just to give you a generalistic view, Crohn's tends to be all over the place, and ulcerative colitis tends to be that lower left quadrant and associated much more with bleeding rectally. So not pleasant conditions. So treatment, again, lots of very similar things you're going to see come up tonight. Calm, reassure in a quiet environment. Full history and observations. Again, if there is any hint of an infection, we'll just do a news too, just to make sure they're not septic. Pain relief, again, Entonox can be very effective again. Again, checking for bowel obstruction, you're likely to have diarrhea in these cases. So fairly happy to rule out bowel obstruction in most times when you have diarrhea. Again, paracetamol is safe, absolutely fine, but again, definitely don't want to be taking anti-inflammatories with the inflammatory bowel diseases. Despite the name, actually you think that would be a suitable option, but they can make things a whole lot worse with particularly when you've got gastric bleeding going on already. Again, monitor closely and transport to the appropriate facility. Flare-ups of inflammatory bowel disease and it can be intensely uncomfortable for the patient. It's very unlikely if you're called to them at 2 o'clock in the morning on an ambulance that you'll be able to kind of arrange any suitable treatment option that doesn't generally involve going to hospital. During the day, there may be other options available to you. And again, if you need paramedic support for pain relief, by all means ask for it. That's what we're here for. So we should be getting on top of these patients' pain as quickly as possible. So good. So now we're going to go to Mentimeter. Now I've confused you all. So back to Mentimeter then. Here we go. So some of you have started answering. So menti.com, say 75747523. Give 3 signs and symptoms of gastroenteritis. And we'll talk through gastroenteritis. 3 signs and symptoms. Good. Abdominal pain, diarrhea, vomiting. Great. I mean, diarrhea and vomiting is obviously the one most people are going for. That's good. Temperature is possible. Yeah. Vomiting, tachycardia. Yeah, possibly. Good one. Loose stools. Absolutely. Loose stools, diarrhea. Good. Low grade fever. I like that. It's not likely to be a huge fever with DMV. Yeah, good. Diarrhea, vomiting, fever, perfect. I think quite a few people going for similar options there. So nothing new coming up. Pyrexia, good. Using the proper one. DMV, like it. Great, well done, people. Yeah, perfect. So we're on the right line. So gastroenteritis then. Gastroenteritis is often bacterial, well, it can be viral or bacterial infection of the stomach and small intestine generally. So it's often caused by food poisoning. It's often caused by contact with other people that have gastroenteritis. It's very readily spread, as you can see some of the examples of the viruses there. But norovirus, when it does the rounds, it certainly does the rounds. And actually, we're seeing a bit of a case of norovirus going around in the area where I work at the moment. Lots of people coming down with it. You get C. difficile as well, which is one of the bacterial infections of the stomach that spreads like wildfire around lots of the wards and the nursing homes. When you get a C. diff outbreak, goodness, you certainly know about it. Everyone works very, very hard. But it doesn't matter what the causative organism is, whether it's a virus, whether it's a bacteria, whether it's a fungus. It's something within the stomach that gets down into the small intestine that the body doesn't want there. Typically speaking, if the body realizes nice and quickly and it's still in the stomach, you just get the vomiting. You don't always get the diarrhea. It depends how quickly your immune system responds and says, but more often than not, you get a bit of both. So those with the stronger immune system, actually, it may drop further down the body before it starts to try and get rid of it all, and you may only have the diarrhea. But either way, it's generally associated with diarrhea and vomiting. It's the gastrointestinal system trying to empty itself of this bacteria. Let's say common causes: food poisoning or contact with someone that has had D&V, diarrhea and vomiting. Again, those of you with kids, I'm sure you'll know, they'll come home with playgroup and they'll have the runs, and then all of a sudden everybody in the house has it, and it just seems to go round and round like chest infections. But the winter vomiting bugs and things, norovirus bugs, they certainly come round. As I say, we're certainly in the throes of one at the moment where I work. So good. So recognition features of gastroenteritis, really quite simple. It is the diarrhea and vomiting with a history that suggests where they've got it from. Again, it is an infection, so there's a possibility of a raised temperature. So you might see that raised respiratory rate and heart rate with the temperature. Again, blood pressure might be low in severe cases. Good dehydration can occur, particularly in the elderly, particularly in the young, or those that are immunocompromised. Their immune systems are quite weak. So GCS is likely to be normal. Blood sugars are likely to be normal again in healthy adults. That even if you are not eating and having diarrhea and vomiting, we wouldn't generally expect your blood sugar to change a whole lot. If you're diabetic, sure, blood sugar might drop down. So we do have to be very careful of diarrhea and vomiting with diabetic patients, particularly type 1, that are reliant on taking the right dose of insulin to control their blood sugars. So diarrhea and vomiting in diabetes is certainly one to watch out for. It's a bit of a red flag and sometimes quite hard for them to manage. But generally speaking, in the adult population, everyone gets D&V at some point, several times in their life. It's unavoidable. So we are designed to cope with it, as horrible as it feels. So good. So raised temperature possible, lots of diarrhea and vomiting, loss of appetite. Dehydration is the main thing we're worried about. If you're likely to die of dehydration within a few days if you can't get fluid in. But of course, the vast majority of people they can get sips of water in between those episodes of vomiting. Again, abdominal pain in these cases, they tend to be upper or middle. Sometimes you get that lower cramping when you're about to have an episode of diarrhea, but it is that cramping pain. It comes and goes in waves. It eases with vomiting or eases with opening your bowels, and then it slowly builds until you feel like you need to do one or the other again. Unfortunately, in the early stages, it's quite common to have both happening at once, as I'm sure we've all been there. Bowl at one end, toilet at the other, hopefully, if you've made it, and not a pleasant experience, is it? So Sadie, good point. So gastroenteritis can be caused by other infections within the body. Very good point. So you had an ear infection, which became a chest infection, which became gastroenteritis. Absolutely. If your immune system's not getting on top of these bugs, they can spread around and cause other things. And actually, again, that's a prime example of when you really got to watch out for things like sepsis, because if your immune system's getting overwhelmed, you've got infections spreading all over the place. It doesn't take much for it to spread into the bloodstream and cause issues, but we'll talk sepsis another time. So good point, good example. Thank you very much. So treatment of diarrhea and vomiting is again the usual stuff. Oops. Series off. The usual stuff, pain relief, again, if they've got pain, Entonox can be effective, absolutely. Again, bowel obstruction is not going to be the case, really, if you're full-on diarrhea and vomiting. It's unlikely that this is going to be anything other than gastroenteritis, albeit the more you read into it, the more you realise sometimes you can get diarrhea and vomiting when you have horrific constipation, when you have complete bowel obstruction and you get overflow, kind of diarrhea, and you get fecal vomiting. But again, the history is going to tell you that the patient hasn't been overly constipated in the days leading up to this. They've just had a dodgy chicken takeaway, and now they're sitting on the toilet feeling like they're going to die. That's gastroenteritis, isn't it? It's not overflow from bowel obstruction. Again, paracetamol is always safe, but again, if they're actively vomiting, good luck trying to get a couple of tablets down. I dare say they've probably been trying before you get there. The key with D&V, particularly in the otherwise healthy adult population, so we're not talking about diabetics, we're not talking about the elderly, we're not talking about cancer patients now. those that are fit and well, we would really like to try and keep these people out of hospital, because actually a lot of gastroenteritis is really infectious, you know, especially if it's C. diff or norovirus. You take that into hospital, all of a sudden you've got an outbreak, and actually those with weakened immune systems, those on chemotherapy, those kids that are newborns, etc., are then being exposed to that, and that could potentially be quite a bad thing. Again, this was the whole theory, wasn't it, when we had COVID, or even now it's still going on when patients have coronavirus, when they test positive. We don't want them in hospital unless there's a complication that can only be treated in hospital. We want them at self-isolation at home. This is no different, DNV. So activated charcoal, no, not so much. So activated charcoal is only really efficient in the first hour. So a kind of acute oral poisoning. So I suppose if you ate something that you knew had salmonella or something like it, you just go and eat a hunk of raw chicken and then take some activated charcoal. I don't know whether that. I don't know. I'm not sure I particularly want to take part in that clinical trial, but yeah, you never know. Only for toxins, as far as I've heard. They're not that pro charcoal. Yeah, no, absolutely. Charcoal's got its uses. I think in acute paracetamol or other oral tablet overdoses, it can be quite useful. But no, I would say in something like this, generally speaking, from eating it to developing symptoms is 18 to 24 hours, isn't it? In most people, sometimes a bit sooner, but activated charcoal won't have any effect by that point. Good. So in the otherwise healthy adult, the general kind of Public Health England advice or NHS advice is that provided that, you know, within the first 5 days of symptoms, provided their observations are normal, it's rest, it's maintaining fluids as best as possible. So sipping Diaurolite. Diaurolite's a product you can buy over the counter. It's available in a couple of different flavors that don't resemble anything like what they're supposed to. It certainly doesn't taste like Ribena, as I often lie to people and tell them it does, but just to get them to take it. But yeah, Diaurolite's not the nicest tasting thing, but it's got some vitamins and electrolytes and things like that added into it that you're likely to lose when you're having diarrhea and vomiting. Good hygiene, you don't want to spread it around the house. It's probably inevitable in most houses that it will just do the rounds, but not always. Good hygiene can help, and particularly if you're having to go out and do anything. Avoiding anti-sickness, avoiding things like Imodium. The saying is it's better out than in. There's a reason why your body's trying to empty itself of something. The longer if you can, by all means, you can artificially dampen down your vomit reflex. You can stodge up your bowel with Imodium all day long. All you're doing is holding that bacteria in. They're actually more likely to develop serious complications as a result. So better out than in is the general phrase. We don't often treat vomiting and diarrhea. And again, reintroduce bland foods slowly. So this is general advice. As I say, don't be afraid to ask for senior clinical support if you're not sure. But the general healthy population really shouldn't be going to hospital with DNV unless there is a complication that just can't be treated at home. You know. But again, other groups, obviously diabetics, chemo, etc., we're going to treat slightly differently. So good. So all army food is bland, good stuff. So there we go. Go back onto army rations then if you've got DNV once you want to reintroduce. So get those. You can get those kind of kits, can't you, on eBay that you see all these preppers, doomsday preppers buying in huge numbers, but yeah, can't say that's particularly appealing. But we'll talk about gallstones. So gallstones are calcium stones basically that form within the gallbladder itself. Okay, so not always understood why they appear, why some people do and some people don't get them. High cholesterol diets are likely to speed up the process. Everyone gets them to a certain point, I'm led to believe, but most of the time they don't cause anyone any issues. So high cholesterol diets are the ones. Excess alcohol can also speed up the process of gallstones appearing. But yeah, stones within the gallbladder itself, what can happen sometimes in the same way as renal stones, we'll talk about them next week, where you get kidney stones, and they're okay, you know, generally speaking, you can have one or two in there and not have any issues with them. It's when they move and when they cause a blockage, it causes some quite nasty discomfort. And gallstones are no different. You get that kind of horrible right upper quadrant pain just at the base of your ribs, particularly after eating fatty or spicy food. So there's often nausea with it. Often kind of patients look quite unwell with this. It's sometimes you can walk into, because the same types of people that get gallstones can be the same types of people that get heart attacks. And actually the two can be sometimes a little bit hard to tell the difference between the two. And again, I'll always err on the side of caution. I always say if you walk into somebody, they're looking pale, sweaty, clammy. They've got some of that kind of pain just under their rib cage. It might be moving across to the middle slightly. Who you say, is it gallstones or a heart attack? Obviously, we've got ECGs to help us in those cases, but actually they can look quite similar. These patients don't look particularly well, and it can be very uncomfortable for them. So really quite common as I say, to get gallstones. Whether they cause an issue is another fact. Some of the complications you can get, so when you cause that blockage in the common bile duct, you can get inflammation of the gallbladder itself. That's cholecystitis, so inflammation of the gallbladder. That can be a surgical emergency. That can warrant immediate removal of the gallbladder. Again, we try not to remove people's gallbladders, because it can affect digestion, it can affect the immune system a little bit as well. But again, it's a fairly common surgical procedure that's done. Other issues you can get are inflammation of the duct up into the pancreas. We can get inflammation of the duct back into the liver. You can also get kind of secondary hepatitis and things like that going on. So Dorothy got Elsie had gallstones, especially it's not pleasant. There's excruciating pain, couldn't dress properly, heading to A&E. Absolutely, yeah. A lot of these, again, by all means, suggest alternate pathways. But I think 2 o'clock in the morning on an ambulance, 111 have sent you for an abdo pain. You get there and you think gallstones. It's going to need a fast scan at least to make sure that it's not an acute cholecystitis and surgical emergency. So. Yeah, jaundice, absolutely. So that's in there, I think, in the recognition features. Here we go, coming up, maybe jaundice. So it can happen if you're getting back up into, i.e. the liver's starting to malfunction because it can't push it's overflowing because the bile can't go anywhere. If the liver starts to malfunction, you can get jaundice, which I'll show you shortly. Is the kind of yellowing of the eyes is the early stages. So again, normal airway, normal response. Again, likely to have raised respiratory rate and heart rate with the pain, and again with the inflammation. If you're getting acute cholecystitis, inflammation of the gallbladder, then there may be a raised temperature there. There may be the possibility of sepsis. So let's have a little look in quick gain or lost weight. Yeah, absolutely, Adelina. Yeah, so patients that have changed weight rapidly can get gallstones as well. Again, that tends to be a fairly common presentation. Yes, Murphy's sign, perfect. So good one, Stuart. So we will talk briefly about Murphy's sign, but having that, so Murphy's sign, for those of you that haven't heard of it, get the patient to lie flat on the bed, get them to, so wedge your fingers underneath the rib cage. You should just about be able to palpate the bottom of the liver. If you get the patient to take a deep breath with your fingers wedged in under the rib cage, it's intensely painful. Murphy's sign is positive, and that can indicate cholecystitis, which is inflammation of the gallbladder. So very good, Stuart. So one useful abdominal exam, worth some CPD, worth having a read around, stuff like that. Good. So again, things are unlikely to change. Again, you're going to get your Murphy's sign possibly, and a normal ECG is obviously pushing you down the lines of gallstones. But again, normal ECG doesn't rule out acute coronary syndrome, so do just bear that in mind. These patients can present quite similarly. So we've got that gnawing, twisting pain in that right upper quadrant, IUQ. Worse after eating, particularly fatty food, particularly spicy food, particularly alcohol. It's painful on palpation. That's that Murphy's sign. If you wedge your fingers up there and get them to take a deep breath, if it's intensely painful, you've got Murphy's sign. And then maybe jaundice, as Dorothy said, which is really quite, well, not common, but it can happen if the liver starts to malfunction. So, what's going on with our numbers there? So again, calm, reassure to the quiet environment, take your full history, get a good Socrates. Entonox, very effective again. Again, your questions to rule out bowel obstruction. Paracetamol is always safe to give. Again, aspirin, ibuprofen, I would step away from in the case of anything acute bowel. Cholecystitis, inflammation of the gallbladder can be a surgical emergency. If you're thinking that, they're probably going into A&E for a scan. Monitor them closely. Consider your paramedic for pain relief if needed. And often these patients do need a lot of pain relief. I think this is certainly one of the cases where morphine is quite often on the menu. So definitely consider your paramedics for help there. So good. I think we're coming to the end of tonight. So we've got one more quiz on menti.com, which is this 3 liver conditions that you've heard of. So menti.com 7574 7523. This 3 liver conditions that you've heard of. So think of what can cause liver problems. Cirrhosis, fatty liver, good, well done. Fatty liver, portal hypertension, oh, very good, very good. Excellent, hepatitis, lovely. Jaundice. So jaundice is a side effect of a liver, an acute liver failure, really. So or chronic as well. Hepatomegaly, very good. So enlarged liver, good. As a result of some of the other things, normally hepatitis or fatty liver, good. Lovely. Alcohol abuse. Yeah, alcohol abuse can cause a couple of the conditions we're going to talk about this evening. Good. Well done. Perfect. Autoimmune hepatitis, very good. Very rare, but very good. Good. Don't worry, I can't spell cirrhosis either. I had to Google it. Perfect. Well done. Yeah, we've got some good ones there. Let's flick back. Let's talk through. So we're going to cover all of those. So liver problems then. So inflammation. Inflammation of the liver is called hepatitis. Okay. And actually there are 7 main types. Okay. So we've probably all heard of hepatitis C, I'd imagine. That's the one that's common in the UK. That's spread from blood-to-blood contact. It's often spread through showing of needles. It's and just general body fluid exposure. So hence why it's one of the main reasons as healthcare professionals anyway, we practice kind of safe sharps. We practice obviously universal precautions in wearing gloves and sanitizing our hands and covering open wounds on our own body. Universal precautions when there's a body fluid exposure risk. So inflammation of the liver, hepatitis A, hepatitis. So these are all just caused by different viruses, and they've just labelled them A to E. That's the only real difference between them. But hepatitis A is not very common in the UK. It's more common in Southeast Asia, Sub-Saharan Africa, etc. And you get hepatitis A by ingesting the feces of an infected person. So it's you're expected to pick that up in places where food hygiene isn't very good, for example. But again, it's not common in the UK. It does happen from time to time. It can also come from infected water, where people are tipping sewage into water streams and things like that, as does happen in some parts of the world. So hepatitis B spread by blood-to-blood contact. Again, it's just a different type of virus. It's not very common over here, but patients that are, again, it's common in the Southeast Asia and Sub-Saharan Africa continents again, where we're seeing patients born with it. It's spread from mother to baby during childbirth. And then baby grows up with it. So there's 2 types. You can with hepatitis B is acute and chronic. Most people get over hepatitis B without too much stress, but then some people develop chronic hepatitis B, which can lead to cirrhosis and other problems later. There is a vaccine for hepatitis B. Those of us in healthcare will have had or will be offered, at least when you go and work frontline, in the hepatitis B vaccine, which is very effective. Hepatitis C, there is no vaccine. About 75% of people infected with hepatitis C will develop chronic hepatitis, and often there's no real symptoms until you develop liver cirrhosis or cancers around the liver. Hepatitis D is quite rare, but it occurs secondary to hepatitis B, so it can only affect people that are already infected with hepatitis B. So that's quite poor luck, isn't it? If you have hepatitis B and then you get infected by somebody, again, blood-to-blood contact, but it's quite rare within Europe anyway. And hepatitis E is on the rise. Hepatitis E is a type of hepatitis that you can catch from raw and uncooked meat. They say pork and shellfish are quite common carriers of hepatitis E. It is on the rise in Europe in general. But there's no long-term complications found yet of hepatitis E. Get over it relatively quickly. It's quite an acute hepatitis, if you like. So, alcoholic hepatitis is inflammation secondary to excess alcohol. When you drink too much, give yourself alcohol poisoning, you can cause inflammation of the liver secondary to that. And then, as somebody mentioned, autoimmune hepatitis, which is where the immune system malfunctions and starts to attack itself. Again, it's very rare, autoimmune hepatitis, thankfully, because it's a nasty condition. So Bad hygiene conditions of dental procedures. Yeah, again, hepatitis can spread. Yeah, blood to blood. Any infection. A lot of these, sorry, should I say? If the bloodstream is exposed to the hepatitis, it will spread. And of course, hepatitis C is considered to be the worst. But hepatitis B does have the potential to become chronic and cause loads of secondary effects. But A and E, you're generally expected to get over it. Alcoholic, of course, if you stop drinking, you should settle it down. So cirrhosis. Cirrhosis is scarring of the liver. Its main causes in the Western world anyway, alcohol abuse, chronic hepatitis, so from B or C, and fatty liver disease. So fatty liver disease, it can be either alcoholic or non-alcoholic. Non-alcoholic is the most common, and that's just mainly obese patients. So if you are obese and one of the places where excess fat is stored is around the liver. If the liver becomes enlarged because of excess fat deposits, sometimes its function can reduce and it become scarred, i.e. cirrhosis can develop as a result. So that's hepatitis, cirrhosis, and fatty liver disease. You'll see those relatively commonly if you go out and work in the community. I've not included recognition features. I'm not including management because actually they're so different. And a lot of hepatitis doesn't actually give any symptoms. A lot of the early recognition features of hepatitis C are cold and flu-like symptoms. Recognition of alcoholic hepatitis is intense right upper quadrant pain that's often mistaken for gallstone problems or gallbladder problems or pancreatic problems, particularly in the alcoholic patients. Again, cirrhosis tends to be pain, tends to be jaundice, tends to be generally not doing too well. Fatty liver disease, enlarged liver, again, getting pain in that right upper quadrant. Again, often mistaken for gallbladder problems. I know the last fatty liver diagnosis I got was a chap that I thought had colitis, well, biliary colic as we call it, kind of an enlarged stone within the gallbladder, and actually on ultrasound we figured out he just had fatty liver disease. So it can be mistaken. Good. So we've got our questions then at the end. Let's see how much has sunk in. I do, just before I go to this, I completely have missed. I was going to just briefly talk about, and I'll flick back to this slide with the inflammatory bowel diseases, because I wanted to make mention of diverticulitis. And diverticulitis is a very common bowel problem in the UK, and it can sometimes be considered under the inflammatory bowel diseases, although it's not a true inflammatory bowel disease. And diverticulitis is where you get little kind of pockets, if you like, little kind of diverticules that grow, particularly within this same area that's affected by ulcerative colitis. So in that descending and sigmoid colon, you often get little pockets. And what can happen, very much like appendicitis, if you remember, some small parts of feces can enter those pockets and get stuck and cause localized inflammation. That's diverticulitis. It presents with left-sided abdominal pain and a temperature. And often with some diarrhea as well. It can be mistaken for ulcerative colitis. The two are very, very similar in their presentation, and both are chronic diseases, if you like. Neither suddenly get better. You get flare-ups from time to time, so can be difficult to differentiate between ulcerative colitis and diverticulitis at times. So that, I just wanted to make mention of that because I realised I hadn't put a slide in. So we're going to flick over to Mentimeter again, and I've got some quiz questions for you lined up. So first one, what are the two main systems affected by cystic fibrosis? So you've got two answers, pop them up there. Good. Perfect. Let a few of you have a vote in there. Good. So respiratory, gastrointestinal, most of you going for that. Digestive system, lungs, GI. Nobody's getting it wrong. Gallbladder particularly, absolutely well done. Gallbladder and pancreas. Not so much the renal system. All systems are affected by cystic fibrosis to a certain extent, but the main systems are the respiratory and gastrointestinal, as people are going for there. Very well done. Perfect. So next question then, staying on the same number, 7574, 7523. What are the two types of inflammatory bowel disease? Good. Colitis and Crohn's. Very good. Perfect. Well done. Sure, I should have done that as a competition, shouldn't I? See who can answer first. Well done. Ulcerative colitis and Crohn's. The vast majority of you going for just different spellings of everyone's. Everyone's got the right answer there. Fantastic. Well done, guys. So, next question, multiple choice then for a change. So John is 18. He's awoken today with right lower quadrant, abdominal pain, diarrhea, and a temperature. Which of the following is most likely? A, B, C, or D? So John is 18, he's awoken with right lower quadrant abdominal pain, he has diarrhea and a temperature. Which of the following is most likely? Ulcerative colitis, gastroenteritis, appendicitis, or gallstones? Try and let half of you vote before we start showing the answers. Have a vote through minty.com, 7574 7523. Right lower quadrant abdo pain, diarrhea and a temperature. Which of the following is most likely? Just slow it down a little bit. Let's see where most people are going. 10% saying ulcerative colitis, 5% saying gastroenteritis, the vast majority saying appendicitis. Nobody's yet saying gallstones. Oh, somebody said gallstones. Just to even it out. Well done. So perfect. The correct answer is, of course, appendicitis. So again, this is where your Socrates comes in really quite useful, doesn't it, when you're differentiating in abdominal conditions. So appendicitis, so the appendix is in the right lower quadrant of the abdomen. So that's the first clue. That fairly rapid onset, he's woken up with it this morning. He's got diarrhea. That's really common with appendicitis. He's got a temperature, again, really common with appendicitis. It tends to be bacterial that tends to push that temperature up. What makes it not ulcerative colitis? Ulcerative colitis tends to be pain on the left-hand side of the tummy. There tends to be diarrhea as well. It tends to be bleeding, less likely to have a temperature. Gastroenteritis, less likely to have a temperature. There would be diarrhea, but there would be vomiting as well. It wouldn't necessarily be right abdominal pain. It tends to be more middle, tends to be more cramping, but again, not the same for everyone. And gallstones, you'd expect to see right upper quadrant abdominal pain, not necessarily the diarrhea, not necessarily the temperature. So of course, appendicitis fits the best there. So very well done. So the next question then is, whoopsie daisy, it won't let me go on. So you decide that it is appendicitis, which of the following statements is true. John can be referred to as GP. John should be given ibuprofen to reduce the swelling. John should be pre-alerted to the nearest A&E ASAP as soon as possible. Or John should be screened for sepsis. Which of the following statements is true? A, B, C, or D? Can you refer him to his GP? Can you give him some ibuprofen? Should we do a blue call to the nearest A&E department? Or should we screen him for sepsis? Interesting to see where everyone's going. Here we are. So let's have a little look where most people are going. Okay. Ooh. So 5% of you saying you can go to his GP. Maybe in some cases in early states of grumbling appendix, sometimes people can go to their GP, but unlikely. If patients come into us with query appendicitis, we refer them to surgeons. So GP is off the cards. John should be given ibuprofen to reduce the swelling. No. With acute abdomen, we tend to stay away from anti-inflammatories until we know exactly what's going on. Just to make sure there's no active GI bleed going on, which obviously anti-inflammatories can make worse. So we're evenly split, aren't we, between John should be pre-alerted to the nearest A&E as soon as possible, or John should be screened for sepsis. A bit of a trick question there. John should, of course, be screened for sepsis. He has a temperature. We should be doing a News 2 score. He wouldn't necessarily always be pre-alerted to A&E. I would only pre-alert someone to A&E who was showing signs of ruptured appendix. And or showing signs of sepsis. I wouldn't necessarily, if somebody had, I think it's appendicitis, Actually, you know, they can make their own way to A&E. They don't necessarily need the ambulance to take them. It all depends on what pain relief regime we're going for. I wouldn't necessarily blue call every query appendicitis to A&E, but again, some may. But I would definitely screen every query appendicitis for sepsis. So D is the most correct answer there. So well done, 43% of you that's got that. I think there's one more question. So you're satisfied in this case that John does not meet the sepsis criteria. Which of the following tests could be performed to help diagnosis? Obturation, psoas, Murphy's, Romberg's, or an ECG? Which of the following would be useful to diagnose appendicitis? Obturation and psoas, Murphy's, Romberg's, or an ECG? Which are you going to do first? I'll let a few of you vote. Let's see where we're all going. Okay. So some bandwagon jumping on there. I see now I've put the answers up. A few people going for B, just because everyone else has. Fine, okay. So the correct answer there is the obturation psoas sign. So Murphy's sign. Murphy's sign is to screen for cholecystitis, which is inflammation of the gallbladder. Romberg's test is a neurological test to look for cerebellar symptoms, so not anything gastrointestinal at all. Romberg's test was something I just threw in there off the top of my head. So Romberg's test is where you get someone to stand with their feet close together, arms down by their side, and close their eyes. If they fall over or if they look like they're going to fall over, that's a positive Romberg's test, and it can give you concern about their cerebellum or their vestibulocochlear nerves, so their balance centers within their ear. So of course, obturator and psoas are the two leg movements that you can do which can put pressure around the appendix, and if obturator or psoas movements increase their pain, then the patient is likely to be positive. So have a look around those. That's good CPD to do as a special test. Obturator and psoas test, lovely. And an ECG. An ECG is not particularly useful in some. I'd say it's not always unuseful in abdominal pain. Some abdominal pain can make you think, is this cardiac, is this gastric? ECGs should be done when you've got those upper GI pains that you can't explain. But generally speaking, in lower GI pains, ECGs aren't that useful. McBurney's point, tenderness, rebound tenderness, absolutely. McBurney's point is when you get referred pain to the opposite side, and rebound tenderness, as we've talked about, when you let go, you get that intense pain. So well done, Stuart. So obturator and psoas, have a look at those. They are useful tests. So, whoops. Good, I think that is it. So let's go back to our one here. I'll just flick it to the end. Since I went back, thanks guys, you've come to the end. I hope tonight was useful. What I will do just before I go too much further is I'm just going to copy and paste the link to get your CPD certificates into the chat. If you just bear with me, I will try and do that without crashing the whole thing. Copy the link, and then if I come back here. Right, so if you go into the chat now, click on that link so you've got it open in your web browser. That is the link to get your CPD certificate. There's a little feedback form you have to fill in, and then it sends you a PDF certificate to your email. So thank you all for coming along tonight, guys. It's been a great turnout, over 80 of you, which is really good. So we're back. So we're away for the next couple of weeks. So I'm going to put that out there right away. So we're not going to be back next week or the week after. So the 23rd of August. We're having a well-earned couple of weeks away, and actually we're in the middle of the New Forest and probably won't have signal. I seem to remember last time we were at that campsite, we couldn't actually get online. So Monday the 23rd of August, we'll be back. We're going to be talking about, I've forgotten to change the title, it's the genitourinary pathophysiology. We're going to be talking about the urinary system and problems with the sex organs. That'll be Monday the 23rd of August. Tonight's session is recorded. It will go up on YouTube within a day or two. PowerPoint slides will be available on the website, and you can, as I say, click on that link that's in the chat. It's disappearing fast. I'll put it in again for those of you that don't want to scroll all the way back. Oh, no, I've sent that to Emma. Sorry, Emma, I've just sent you a link. Everyone. Send it to everyone else, not just Emma. There we go. So if you click on that link, you'll be taken to our website. We can fill in a form and get your CPD certificate. And I hope to see you again on Monday, the 23rd of August, when we're doing genitourinary pathophysiology. And in the meantime, if you have any questions, I'd be more than happy to answer them, whether it's on tonight's session or otherwise. I'd just like to say at the end, if you've enjoyed tonight, then we really do appreciate it if you could leave us some feedback, either on Facebook, Trustpilot, or Google reviews. It really does help us, as I say, turn these webinars into people booking onto our paid courses, and that obviously allows us to keep these webinars free of charge. So if you do have a minute just to leave us a review, we would really appreciate it. And as I say, hope to see you again on the 23rd, and tell all your friends, and everything will be on YouTube in a day or two. I'll take questions. I'll stop the recording.